Low back pain is complex, I guess that's what I'm trying to say. And I feel like people who struggle with chronic low back pain, they feel lost. They feel frustrated. They feel like they don't have control. Many of them live in fear. They're afraid of the low back pain. They're afraid of certain activities. Many people get sold a lot of things that they don't really need. Feeling fragile and being afraid, that's not a good way to go through life.
Welcome to Build Beyond, a podcast designed to challenge and guide you on your health journey so that you can meet your full potential.
For this episode, I want to take some time to talk about low back pain. Low back pain, I think it's the largest cause of disability globally. I don't have a reference for that, but I've read it several places. I think the estimate is like 80% of the global population will deal with low back pain at some point in their life. Interestingly, I read that the leading cause of disability in the United States is depression. So I don't know. I think they're both kind of a problem. But you can imagine that if 80% of the population is going to deal with low back pain at some time, and depression is a huge issue, that there's some overlap there. And I will just say, I guess from clinical experience, if someone's struggling with both depression and low back pain, it's really hard to treat the low back pain if the depression is not in check, if they're not working on that. And I don't think it's necessarily a cause or effect relationship. So I'm not saying that if you have low back pain that you're going to become depressed, or if you're depressed, you're going to have low back pain. But I have noticed that if I have patients struggling with low back pain and they're struggling with depression, it's very hard to get the outcome that they want until they get that depression under control, which as a chiropractor is obviously not something that I treat directly. Although I would like to think that I'm part of the care plan, the overall care plan to help people get through that, but definitely not taking the lead on depression. Why do I bring that up? Low back pain is complex, I guess that's what I'm trying to say. And I feel like people who struggle with chronic low back pain, they feel lost. They feel frustrated. They feel like they don't have control. Many of them live in fear. They're afraid of the low back pain. They're afraid of certain activities. Many people get sold a lot of things that they don't really need because feeling fragile and being afraid, that's not a good way to go through life. And it's easy to be led down the wrong path. So low back pain's a problem. And sadly, we're not very good at dealing with it, even as chiropractors. It's such a big issue. And I think it's one of those categories in healthcare where we struggle. And because of that, people struggle. And I think because it's so common, it's very easy as a healthcare provider to get in this pattern of thinking, I've heard it all before, because I see low back pain all the time, every day. And I think it's pretty common for primary care physicians as well. I can't speak for them, but I have some friends who are physicians, and I know that's a very common thing, that someone will go to a primary care provider complaining of low back pain because it's an issue. So as a healthcare provider, regardless of your specialty, if you see it a lot and you hear it a lot, and it's not a life-threatening issue, you tend, and it's just human nature, you tend to lump people into a category. Oh, it's low back pain again. And that tendency is really strong. It's really hard, especially as a chiropractor, it's hard to fight. And I've spoken to other chiropractors who, and I've asked, how do you deal with it, or how in depth do you get with your questioning with low back pain? And sadly, I think a lot of people, especially people who have been in practice a long time, they tend to get in a rhythm and they ask fewer and fewer questions, and they dive into it, and they categorize less. They dive into it less, and they categorize people more. And I think that's unfortunate. I think it's human nature, but I think it's a problem. And it's maybe why we don't get as good of outcomes with low back pain as we probably could. Now, this podcast episode is really intended for people who are struggling with low back pain, or who are afraid of low back pain, and who need help. They need answers. So if you're someone who says, I have chronic low back pain that comes and goes, and I love my treatment plan, I love my methods, I love the doctor I see, I'm not going to lobby for you to change. you can still listen to this, and even if what I say in this podcast contradicts what your healthcare provider is saying or doing, if you are happy with that healthcare provider, you're happy with that plan, I don't think you should change. So I'm not here to persuade anyone. I'm really speaking to the people who are lost, who are looking for information. And I want to start this podcast with a story. This is a combination of a couple stories, but I think it represents, I don't know, it represents real people. So a woman with low back pain comes to see me. She has very typical low back pain. I'm air quotes typical. I mean, I've seen it all before. That's my initial thought. Describes low back pain as everyone else does. She's got pain with sitting. She's got pain with bending over and picking things up. It's just very unremarkable in its presentation. She's had this for quite some time, let's say 6 months. So we're getting into that chronic range. She's had it before, but it's never been this bad. And she's distressed about it. And her level of distress is higher than what I would expect. It almost catches me off guard. So we dive in deep to what's going on with her, talking about specifically about her low back and everything. Again, like nothing is like, this is so common. Now, at some point it dawns on me, I've got her sitting in a chair, a soft chair. So sitting for a long period of time in a soft chair, one of the things that she says is provocative for the pain. So I'm just sitting there thinking, I'm not going to have her move, but oh man, I'm setting myself up for failure as a healthcare provider because I'm probably going to increase her low back pain. She gets through telling me everything about her low back pain, and I'm sitting there thinking, like, this is not a big deal. Now I'm not being empathetic at this point, but again, her level of distress does not fit the presentation. It doesn't. I don't understand why this is such a problem for her. So I go into, we step away from the low back pain and we just look at the overall health history. And lo and behold, she's a real person. She has other things going on in her life. So like many people in the Midwest, so I live in Michigan, seasonal depression is a problem. And she is someone who deals with it. And a lot of people do. So typically she would manage it with medication. But the interesting thing is that this time around, she stopped her medication prematurely without talking to her doctor, and she went cold turkey. Now, I don't know a lot about medication. So in my mind, maybe that's not a good thing. I don't know. I can't. So I'm already thinking like, okay, possibility here. Maybe this is something to do with her medication. Now, the interesting thing also is that she is still dealing with seasonal depression, but we've moved into spring. It's warm. And I asked her about it. She said, I don't know. It's weird. Usually I'm better by now. And so she's seen a chiropractor. She's seen her primary care physician, and the primary care physician sent her to physical therapy. The diagnosis, what she remembered from the medical doctor, I think is totally plausible. Like it was on my list of possibilities. Very logical diagnosis. The PT went off that, very logical, and based on what the PT had recommended for rehab, great starting point. Like I have no problems. This should work. And she'd also seen a chiropractor who was in line with that diagnosis as well and was treating it with chiropractic adjustments. And again, you would think she probably should respond better than what she had been responding. So again, it's not adding up at this point. But I start to tell her about this association with low back pain and depression, and how it's really hard to get results with low back pain if depression's not in check. And her eyes got wide, and it was like a light bulb turned on. And she said, no one's ever told me that before. It was news to her. And I said, yeah. And the low back pain is super common. Depression is super common. You're not necessarily broken. I'd say you're quite normal. You're just dealing with two very difficult things, and they're overlapping. And the analogy that I like to use is, and I didn't come up with this, is if you think about like a cup, a lot of things can fill up a cup, and then whatever you put in last and it causes it to overflow. That's maybe when you have really bad pain or you're really struggling in life. We tend to look at that last thing that got poured in the cup. And in this instance, it was low back pain. But she was already dealing with depression. And I dug a little bit deeper, and she had an ongoing chronic medical issue that I only really got to like 30 to 45 minutes into the conversation. And she had had several rounds of treatment for this in the past that had been unsuccessful. And she was going in within the next few months for another round of treatment, which she was afraid would not work and was afraid that it would be the last time they would try. I can't give you more information on that because I really don't want to, I wouldn't want to give this away, but that weighed heavily on her. She was afraid. And more than fear, she felt like a burden on her family. And so this woman, like most women, was trying to be super mom and super wife. And she felt like her medical issues were weighing down on the family. She felt like her back pain was also weighing down on the family, and she was having pain with household chores, and all these different things were coming together. And she said, at the end of the day, after everything, if I could just relax and enjoy my family, and I haven't been able to do that in about 6 months because I'm in so much pain at the end of the day, and she's depressed. So she's in physical pain, and life just doesn't seem as good. And the only thing she looks forward to is hanging out with her family, and she can't do that. And she's losing that, and she feels like a burden. Well, the vast majority of this conversation, which I think went on, the conversation I'm thinking of went on for a solid hour. It was less of a conversation and more of me just nodding my head and saying, well, what else? What else? Because keep in mind, I am not a healthcare provider. So as soon as we start getting into this mental health stuff, I screen for it. I want people to open up, but not that much because I'm not trained to handle what comes out. But I also don't want to stop people. So it was really just her venting. Now, she'd been sitting down for at least an hour. And this is in the back of my mind where I'm thinking, oh man, how am I even going to trust this? I probably just crippled this lady. I said, hey, out of curiosity, what's your back feel like right now? She goes, I don't feel any pain. And I said, no pain at all? She's like, yeah, it's a little achy. It would gone down. And I said, well, when you came in here, you said it was like a 7 out of 10 and you were moving pretty slowly. Can you stand up, move around? And she says, no, she's like, maybe a 2. I mean, it had gone down drastically. And I said, well, that's odd because sitting for prolonged periods that's what makes it worse. Why do you think this is better? She said, I don't know. Maybe it has something to do with what you'd said about depression. She's like, I don't know. I just, needed to talk to someone, I guess. I don't. And I said, yeah, I here are my recommendations for her was, 1, you need to go back to your primary care physician and talk to them about this medication thing. Get that straightened out. And ask about a referral for mental health, because obviously venting is helping you. And then maybe re-engage with physical therapy or chiropractic, or you don't necessarily have to use me as a provider if you want to go back to the people, because if something doesn't work, if you have pain and something doesn't work, there could be things going on. The diagnosis could be wrong, in which case everything after is probably just a waste of time. Sometimes the diagnosis is right, but there are multiple other things going on and you're only focusing on one thing. And I think that was maybe the case here. Like the pathoanatomical diagnosis of whatever they diagnosed was probably right, but we didn't address all these other things. So I was like, you should go back, and I think if you're cognizant and you're trying to work on these other things, like this should get better, I would expect. Now, if you're in pain and you're going through care and it's not working, the diagnoses could all be right, but the treatment plan could be wrong. Or the treatment plan could start off right, but it doesn't progress as you need to. And this is a big problem with rehab. So I think as a chiropractor, our rehab in school is, at least mine was limited. It was good, but it was limited. Physical therapists get a lot more of it. I primarily do rehab in practice, but it has a lot to do with the strength and conditioning background and a lot of continuing education. Actually, a lot of continuing education with physical therapists, taking physical therapy courses and hanging out with PTs to try and help to learn. So what happens in rehab a lot is that we underdose people. we start off at this really easy level, which is usually appropriate. But the rehab never progresses. So it's like maybe someone wants to has got low back pain and it's really bad. And they want to get back to roughhousing with their 12-year-old grandson. Like it's an older gentleman who wants to do that. Well, that's hard. You know what I mean? So that rehab, yeah, I might start off really simple with some stretching and some walking and some stretchy bands, and maybe that all will stay in there. But at some point, we would have to move well past that. So maybe the diagnosis is correct. Maybe they got all the different factors. Maybe the treatment plan started off great, but maybe the treatment plan didn't go as far as it needed to go. So if you're struggling with low back pain and you feel lost, maybe you feel hopeless, you're scared, in general, you are not happy with the way things are going and you want something better, you might want to consider other factors and consider finding a healthcare provider who's going to look at all those other factors and then chart a path that's going to actually move you towards that goal long term. Now, to help you with this, I looked up some references. Now, people don't like reading research, so what I'm going to do, I'm going to give you some cliff notes right now. And I will list the references in the description of this, and I am in the process of turning this into a blog post as well. So by the time you listen to this, the blog may already be up, but after I publish this, within a week or two, I'll have a blog up with bullet points with everything. So what I thought would be fun is I went to the American Chiropractic Association website. The ACA is like the American Medical Association, but for chiropractors. So it is probably our biggest national association. There are a lot of them, but this is kind of like the overarching. Everyone looks to the ACA. So what are their guidelines for low back pain? Now, this is interesting. So the ACA does not have, at least now, as I'm recording this, their own specific guidelines. They reference two other resources, and this was updated in 2017, and it's early 2025 right now when I'm reading this. So maybe they'll update it soon. They said that they adopt the recommendations they adopt, but the recommendations are not limited to these two documents. One of them comes from the American College of Physicians, and specifically for low back pain, and the other one is best practices for chiropractic management for adult patients with mechanical low back pain. So this is clinical practice guidelines for chiropractors. So the American Chiropractic Association says these two documents, this is what we recommend right now. So let's go through these, because I think this will be interesting. If you're currently or you have gone through care for low back pain, you could start to think about, did my care look like this? Right? So let's start with the chiropractic guidelines, because I'm a chiropractor. So this is best practices for chiropractic management of adult patients with mechanical low back pain. Patients need to give informed consent. Now, you sign a consent form. It's arguable whether that's informed consent, because you can read it, but what this article says is informed consent includes an explanation from your chiropractor of the procedures, so diagnoses, examination, your treatment, and your non-treatment options. There should be an explanation of the benefits and the risks of your different options. There should be dialogue between the patient and the doctor. So we're talking about questions and answers. You should be able to ask a bunch of questions, and they should be able to answer them to the best of their ability. And they should ask you questions to not test your knowledge, but to test your level of understanding. I'm saying things to you. They make sense to me, but I went to grad school for this. What are you hearing? Say it back to me. Explain your level of understanding. And a lot of this is an ongoing conversation. It's not one. There's a lot of dialogue there. Explanations should use terminology that the patient understands. And understanding, they say, is basically essential for the shared decision-making process, because that's informed consent. If you don't understand something and you give consent, it's consent, I guess, because you signed a form. Is it informed consent? I don't know. I guess that's debatable. The article goes on to say that DCs need to establish a management plan using relevant, evidence-based thought processes based on history and physical examination findings that support the working diagnosis and the differential diagnosis. That's a mouthful. So when you come in off the street and you have low back pain, it could literally be anything. Like every diagnosis under the sun is fair play. As we have a discussion, I narrow that down. As we go through an exam, I narrow it even more. At the end, when I decide to make recommendations, there's a limited number of things left. And I look at those things and would say, well, would the treatment, regardless of what it is, out of this pile, would the treatment recommendations vary drastically? And if they don't, then, maybe we don't nitpick. But sometimes it's like it could be this and it could be this, and they're very different. And you need, as a patient, you understand what both of those pathways look like. So that's the differential diagnosis process. And it should be explained to a certain extent. Now, do I go over specific pathoanatomical diagnoses with patients? Very rarely. Actually, never, unless they ask. I don't withhold that information, but most people don't want to know. They don't want to hear scientific terms. What I do is, like, if they have fears, so if they come in and I'm scared that it might be this, this, and this, I will address those specifically. Other than that, I talk more about prognosis. So how good can it get and how long is it going to take? Right. Because that's what people care about. And like I said, beyond that, if my patients are curious, I can go into the actual diagnoses with them. So this article acknowledges that psychosocial factors influence pain. So mental health, your social interactions. So doctors of chiropractic should ask patients about the factors that may delay recovery or amplify pain. Examples: mood or sleep disorders or work-related factors. DCs should take a thorough health history. This gets skipped a lot. You might fill it out, but did they go over it? I mean, like, did we really look at it? I don't know. I don't know. I guess I don't want to throw anyone under the bus. I could get inflammatory with this, but I think it's a weakness within the profession. We'll just say that. We need to consider yellow flags, which may predict poor health outcomes or prolong recovery time. So these include other medical conditions, right? And understanding those conditions, for example, depression, psychological factors, other psychological factors, physiological factors, including, and then you have to think about beliefs about pain and treatment. So we've all heard of the placebo effect, right? You can have something that's not a drug or not an actual treatment, but someone believes that it is, and therefore they get the positive benefits of it. Well, there can be a nocebo effect. And the nocebo effect is that there is nothing noxious that's going to harm you, but you have a fear of it, and therefore you actually amplify that poor outcome just out of your expectations. Attitudes, emotional states, and just pain behavior. So, for example, physical activity is good. It's good for your health. It's good for pain management. But when you're in pain, physical activity hurts, and people tend to be afraid and they do less of it. Over a prolonged period of time with chronic pain, as physical activity goes down because of pain behaviors, it's not a good thing. So we have to look at those. This article says, do not use imaging. So we'll say X-rays for a chiropractor, because that's usually what we have. Do not use X-rays routinely to identify the pain source for low back pain in the absence of red flags. What's a red flag? You fell off a building, you got hit by a truck, like some type of trauma, or if there's something maybe in the history where we're thinking like a pathological fracture, maybe you have osteoporosis and you slipped and you fell. You could have progressive neurologic deficits. There's a lot of different things where that would be a red flag. And we're like, ooh, we should probably image that. But that's like 2% of the people who come, I think statistically, somewhere around 2%. So if you are unhappy with your care right now and you're going to a healthcare provider, let's say a chiropractor who x-rays everybody and uses that as an analysis tool to tell how to treat, that's not within the guidelines. It's important to note that is not within the guidelines. that are supported by the American Chiropractic Association. They fall well outside of those guidelines. And this is going to be, I don't know, this rubs some people the wrong way because there are a lot of named chiropractic techniques, like people practice a specific technique named after a certain person that require X-ray analysis. It's a weird thing because a lot of them get taught at chiropractic schools, yet the American Chiropractic Association is saying it's not valid. Like that analysis method for everybody is not valid. So again, it's a sore spot within the profession. If you're out there and you're with a provider who X-rays and you love it, just keep going. Don't listen to me. But if you're unhappy, yeah, they're probably barking up the wrong tree, looking at treating specifically off of X-rays. This article says, consider imaging under the following circumstances. So if you have no improvement after a reasonable amount of time, so like 4 to 6 weeks, yeah, go to imaging. I think that's a good reason. Maybe you missed something. If there are any red flags, as I said, like trauma or anything in the history or in the physical exam that doesn't add up, you can get X-rays. If you have severe and or progressive neurologic deficits, so you've got foot drop, or like you've lost function, you're starting to lose sensation in your hand, and then it just keeps getting worse and worse and worse. And now you're starting to lose function. That's not good. Severe spinal trauma or some kind of severe anatomical deformity. So if you've got really bad scoliosis, like really bad, like you're really twisted and you can see it and it's getting worse. If you're not under care, you might want to go look at that, and they're probably going to image you. Now, this article goes on to give you management considerations. So they want us as chiropractors, we should educate and encourage patients to self-manage and use non-drug approaches if possible. We are supposed to co-manage and collaborate with the prescribing physician if a patient is taking medication. So if you're going, okay, this is hard because I'm trying to be diplomatic about this. I'm talking right now to people who are already in chiropractic care. If you're going to a chiropractor who is actively telling you to not take your medication, or is like, is somehow trying to influence that choice, that is not within the guidelines, is not within our scope of practice. They can have their opinions, but those opinions are best verbalized with the prescribing physician, not with the patient. So if you're getting that kind of pressure, I don't know, that might be part of your problem. All right, maybe you need to find someone else. We need to educate. We need to use active interventions as early as possible. So active care is like physical activity or rehab. So active and self-care interventions could be exercise, it could be nutrition, meditation, yoga, and just other lifestyle changes. We need to educate patients to better engage and better engage with them and with their care, and to encourage self-efficacy. So we should be trying to keep people out of our office to the greatest extent possible, not trying to keep them in. Now, that doesn't mean you can't have a treatment plan, even a long-term treatment plan, because some people have issues. You know what I mean? There's a lot of diagnoses, a lot of things that are just going to take time. So yeah, you would, in those cases, you would want a treatment plan that ultimately gets someone to where they want to be, but it shouldn't be, I'm talking about that getting adjusted once a month for the rest of your life, like that kind of scenario, not within the guidelines. Passive interventions may be useful, right? May be useful in the initial stage of patient care and management. So by passive care, we're talking about medications, manual therapy like chiropractic adjustments, massage, and then different modalities. So laser, e-stim, shockwave, things like that. We should be combining passive care. So by passive care, you're lying on a table, having someone do something to you, and active interventions like exercise and rehab, particularly self-care, and include provider reassurance. So we are holding their hand, working them away from the clinic long-term. Clinician philosophy and attitudes or our financial considerations should not play a role in clinical care recommendations. this is another one. I honestly feel like this is going to be a sore spot for a lot of people. And you know, even though I don't agree with the way a lot of people treat, I empathize because you have to make money as a healthcare provider. Like we have to make a living. And there are a lot of people, a lot of chiropractors who bill insurance, and that's primarily where they get their reimbursement. Well, the problem with insurance for chiropractors is that over time, insurance reimbursements have been going down, where the cost of everything else has been going up. So it becomes a game. It's a billing game. You have to bill as many codes as possible to stay in business. And so X-raying everyone, those are billable codes. And you kind of have to justify doing as much as possible in as little amount of time as possible if you're billing insurance. And it's if insurance is a big part of your reimbursement plan. And again, I don't know the solution to that. That's a government issue. I mean, it's hard. So again, I empathize with chiropractors or any other healthcare provider who feels like they're stuck in that. But, it's something to think about from a patient's perspective. Are the recommendations that you're getting based on financial considerations of the provider? Okay. I lost my place. Okay. Provide a short trial of care for people with acute pain. So less than 6 weeks, right? Acute pain, if it's not an injury, like you didn't break or tear, not trauma, it should get better quickly, right? And if it doesn't, you got to look into that. Consider that spinal manipulation, so chiropractic adjustments for low back pain, is associated with a reduced likelihood of opioids and adverse drug events. That's, I have actually seen some research on that. And I think that's a really positive thing. If you're someone who thinks you might, like the pain's bad enough, you're considering opioids, going and getting adjusted, that might be a good option for you. Consider that spinal manipulation for low back pain is associated with a reduced likelihood of surgery. Again, if you feel like you're facing surgery, there's a lot of options out there. I'm not saying don't get surgery, but you've got options, at least things to consider. Now, those are the recommendations for chiropractors. Still on the ACA website, they said, hey, here's some guidance from the American College of Physicians. So this is called non-invasive treatments for acute, subacute, and chronic low back pain. So this is interesting. This is for physicians, but it's endorsed by the American Chiropractic Association. So this one's talking about breaking it down: acute, subacute, and chronic. So what does that even mean? Well, acute pain is, let's say, anything less than 6 weeks. Subacute would be like 6 weeks to 3 months. And then chronic, we'll say greater than 3 months. So here are their recommendations for acute and subacute. So this is up to 3 months. Most people with acute or subacute low back pain improve over time, regardless of the treatment. I've seen that so many times. When you look at you compare things. So you compare spinal manipulation, chiropractic adjustments, and doing nothing. We tend not to. A lot of these treatments, even exercise, kind of, and rehab doesn't necessarily outperform time and just waiting. Doctors and patients should select from these options from non-pharmacological treatments, so these non-drug treatments. They said superficial heat, and they rate that as moderate quality evidence. Massage, acupuncture, or spinal manipulation, so getting your back cracked. Although they recommend it, they say there's low quality evidence to support those. They said that if pharmacological treatment is desired, they want you to select NSAIDs, so non-steroidal anti-inflammatory drugs, or muscle relaxers, and there's moderate quality evidence for this. Now, I think it's important to state, I am not recommending this as a chiropractor because that's outside of my scope. I am reading the American College of Physicians guidelines right now. And again, I'm going to link all this in the description. So I don't want anyone to say that Dr. Nelly was, recommending drugs. I'm not. I'm reading from these guidelines just so you know that you're aware of them. Okay, so that's for acute and subacute. Essentially, the way I look at this is they're saying it's probably going to get better on its own within at least 3 months. Do what you need to do to take the edge off and not get addicted to opioids, basically. So let's look at the chronic recommendations. So now we've crossed over that 3-month period. Maybe you've tried some of these acute and subacute recommendations. Maybe you haven't. Maybe you just waited. You just gave it some time and then, it didn't work. Okay. So they have moderate quality evidence for pharmacological treatment with exercise, with multidisciplinary rehab, with acupuncture, and with mindfulness-based stress reduction. That's interesting. And I can say I've experienced this as a patient. If you're going to go with like a cortisone injection or something, some kind of strong anti-inflammatory or painkiller or something like that, you get a window where you feel pretty good, ideally, if they get the right spot. That's a great time to get back into rehab. And I think for some people, it's the ideal time to go see a PT or a chiro who does rehab or a really good personal trainer who's used to working with these things. And then the mindfulness-based stress stuff. I did a podcast not too long ago on anxiety, and it was all about mindfulness. I didn't know much about it. If you want, refer back to that one. I don't know the number, but there's not too many podcasts at this point. I think that's pretty interesting. Now, those are moderate quality evidence. Now they're going to go to low quality evidence. They said Tai Chi, yoga, motor control exercises, progressive relaxation, laser, blah, blah, blah. There's a lot of stuff in here. And spinal manipulation. So they do throw in chiropractic care. And they say it is part of their recommendations, although they acknowledge that there's really low quality evidence for it. Now, even though this evidence for these therapies is low to moderate quality, the American College of Sports or the American College of Physicians rates this overall recommendation for chronic low back pain to be strong. So they feel like, hey, if in the unfortunate event when this crosses 3 months and you're in this chronic phase, we kind of feel like we can do something with these recommendations, like some combination of these. Now, they have chronic recommendations for non-responders. So this is for the people who you went those 3 months and it didn't get better or didn't get what you want. And now you're in that chronic phase and you're working with somebody and you're not responding and you're not getting what you want. So if you have an inadequate response, you could look at pharmacological treatment with non-steroidal anti-inflammatory drugs as your first line therapy. So we could go a little bit more aggressive with the medication. Clinicians should only consider opioids as an option if in patients who have failed the aforementioned treatments, and only if the potential benefits outweigh the risks. And that's after a discussion. So the patient really needs to understand the risks. And the American College of Physicians rates this as weak recommendation with only moderate quality. And so that's it. I mean, these articles are exponentially longer, and I'm just kind of I'm really giving you the Cliff Notes version of it. But as I said before, we're not very good at low back pain. Now, just for fun, I looked up another article because this is something I'd read a while ago, and I referenced it on a couple podcasts, I think. Maybe there's a couple blogs. I don't know. I've used it. I like this. So this was published recently, 2019, fairly recently, in the British Journal of Sports Medicine. That's where I found it. The title of this article, what does best practice for musculoskeletal pain look like? So they're not just talking about low back pain. They're talking about muscle, joint, bone, like what best practices. So this is a bigger net. We're casting a bigger net here. We're not being specific low back pain. And they said 11 consistent recommendations from high quality clinical practice guidelines, a systematic review. So what I was talking about before with these are these, the two papers that I talked about before. This paper essentially took a bunch of them and put them together and juxtaposed, I don't know, looked at them and said, hey, here are some consistent recommendations. This paper, they broke it down into should do recommendations. So you should definitely do this. Those are recommendations that should be applied in all circumstances unless there is a rationale not to. And these are based on strong evidence, such as multiple high-quality studies reporting clinically relevant positive effects. The next tier is could do, right? So could do recommendations could be applied depending on the circumstances of individual patients. They are usually based on consistent evidence of multiple lesser quality studies. They have do not do, so don't do these. These are recommendations that are recommendations applied when there was strong evidence of no benefit and or harms outweigh the risks. And then there are uncertain. This is interesting. So here's just the summary of it. Again, this is a pretty long paper. I'm going to give you the 11 recommendations that they're talking about. Care should be patient-centered, right? So not doctor-centered, not therapy-centered, patient-centered. This includes care that responds to the individual context of the patient, employs effective communication, and uses shared decision-making. So we've got informed consent rolled up right in there, talking, dialogue, asking patients, patient-centered. So this lines up with what we've already talked about. We should screen patients to identify those with a higher likelihood of serious pathology and red flag conditions. So this is that differential diagnosis process of not just looking at the issue, the complaint, but looking at them as a person. Are there any serious red flags here in the history or the exam that are higher? Not that we're not going to deal with the low back pain, but for example, if someone has cancer, who cares about their low back pain? You know what I mean? We got to get the cancer taken care of first. And again, it's pretty rare. Like you're talking, I mean, cancer's not rare, but I'm saying that like people with low back pain coming in to see a chiropractor, I've seen it like once, twice. Most people don't walk into my office. We should assess psychological factors. So we got to think about anxiety, which is a big deal now. Especially, it's a big deal with everybody. I feel like with older populations. So let's talk about boomers. I think it's a problem. I just don't think that they like to deal with it. Millennials, I'll throw myself in there, although I'm an elder millennial, I would say. I think it's an issue with us. I think it's the younger generations, the younger millennials, and then everyone after who really grew up with social media. Social media wasn't a thing really when I was in college. Like Facebook was invented, or MySpace was invented, and then Facebook, I think, became a thing as I was graduating. Smartphones weren't a thing. There's a lot of anxiety right now. A lot of anxiety around politics. A lot of anxiety around the environment. There's just so much going on that people are so connected now. It stresses people out. So we have to think about those things. We have to think about stress, depression, anxiety. Those are big ones. So that's number 3. Number 4 of the 11 recommendations, they said radiological imaging, so we'll just say x-rays for this, is discouraged unless there's serious pathology suspected, right? There has been an unsatisfactory response to conservative care, right? So like this is going on way too long. Progressive signs and symptoms, you just keep getting worse regardless of care. And if it's likely to change the management. So again, I'll go back to, you come in to see me for low back pain. I don't know. Like everything's on the table. As you're telling me things and I'm asking you questions and we're having this discussion, I'm getting rid of stuff. At the end of that discussion, I'm 90% sure usually for most things. And then we do a physical exam. We kind of confirm, maybe refine a little bit more. And then I look at whatever's left on the table. If what's left on the table, one thing would require imaging and everything else wouldn't, we've really got to talk about that, my concern about the thing that would require imaging. And that's probably why we're going to go to imaging first, because I'm worried about it and I want to rule that out. And usually for things where you're going to need imaging, if you skip that and you go to another step, you could have the potential to make things worse. We're talking about such a wide variety of things, but that is to say that imaging everybody is not a thing. It shouldn't be done. It's not within any guidelines that we're talking about. So people who do that, if that's the kind of care that you get and you're wondering why things are bad, that's a big sign. It's a big sign that you're in the wrong spot to me. So number 5 recommendation, we should undertake a physical examination, which could include neurologic screening tests, an assessment of mobility and or muscle strength. I think those are, I feel like in chiropractic school, that's something they did a great job of teaching us how to do. Now, does it get done in practice? I think it depends on the provider, but patient progress should be evaluated, including the use of outcome measures. I do that. I don't know. Outcome measures, that's like when someone, a lot of times when they have you fill out a form and then then you fill out again at some point. I use a variety of them depending on the person. I don't really have a set one, but I think they're valuable. Especially if you're going to have someone, it might not be that valuable within the first 6 weeks, but if you've got someone with chronic pain, I think they can be quite useful. Patient progress should be evaluated. Oh, I said that. Okay. Provide patients with education and information about their condition and their management options. Can I make a critique about my own profession? I think, I've said this before, I've written it in blogs. If you've got low back pain and you go to a shoe store, they're going to sell you shoes and tell you it's going to fix your low back pain, or at least suggest it. They're not going to try and sell you anything else because that's what they sell. If by chance you wander into a mattress store, they're going to recommend a mattress. I mean, that's what they sell. You can't really blame them for that. If you go to a chiropractic office and they adjust everybody and x-ray everyone, and they recommend x-rays and an adjustment, I mean, what treatment options are they really? I'm not saying they shouldn't do that because it might warrant it in specific cases, but if you know 100%, or you can with a lot of certainty guess the exact treatment plan that someone's going to recommend before you walk in, then it would really be up to you as the individual to know that that's the best thing for you. And you might, I don't know, maybe you do. Maybe previous experience, maybe you're a healthcare provider, maybe you've done a lot of research, you can learn a lot on Google. So I wouldn't discourage you from doing that, but it's hard. I've seen it, what is the exact term? There's a term for it, like the shopping market effect or the supermarket effect. So imagine me as a husband with a very vague shopping list, and my wife says, go buy chips. And I go to the chip aisle. Like, what do I do? What? There's so many options. Have you ever been to look into the chip aisle? Even if she narrows it down and says, get tortilla chips, I can make a decision based on myself, but is she going to be happy? And how do I make that decision? Well, things are strategically placed at eye level. There's strategic colors and marketing and things going on. There's so many different options. So how do I make that choice? Well, I might make it based off of a recommendation, a previous experience. There are so many factors that go into that decision. And I think it's a really good analogy for how we select healthcare. So with low back pain, you have a lot of options. Do you see an MD, a DO, a PT, a chiro? Do you see a massage therapist? Should you go to a podiatrist? Should you go to a running store? Should you see a personal trainer? Should you see a mental health professional? I mean, and then let's say you pick chiropractic, well, there are a lot of specialties and subspecialties and different techniques, and how do you make that choice? And people just make choices sometimes. So, regardless of who you pick, that provider, ideally, based on recommendations, should be offering education and information about your management options, even if those options end up with you walking out of the door and not doing treatment there. We should be providing management addressing physical activity and or exercise. This is a big one. Again, I'm going to pick on my profession a little bit. And you may live in an area where this isn't true, but this is just my experience that chiropractors will put manual therapy up on this pedestal. It is the center of our treatment philosophy and our care. When the American the physician paper that I read, so there's really low quality evidence for it. And this other paper said you could do it. And the American Chiropractic Association with the chiropractic recommendations is like, yeah, you could. I mean, it's not essential. And I know chiro means hands, and that's how our profession was founded, but there's just not a lot of evidence to support it being the center of care. If it's a nice adjunct, you can add it on. It can be beneficial. I don't want to say that it's not. But first and foremost, we should be providing management that addresses physical activity and or exercise, because that there's no second and third order benefits to getting your back cracked. Regardless of what our chiropractic philosophy says, it doesn't make you healthier. And we have no evidence to support that. We do have evidence to show that walking makes you healthier, that resistance training makes you healthier, that aerobic activity makes you healthier. Those are all options that you have for managing low back pain. And within all of those choices, there are sub options. So now in research, and I'm generalizing here, getting your back cracked does not outperform doing nothing if you have a large enough population. But exercise doesn't outperform doing nothing. So if you're like, well, I'm going to do nothing and I'm not going to be active, you're going to lose a bunch of health benefits from losing your activity. If you're just going to get adjusted and you're not going to be active, you're going to lose a bunch of those benefits. If you decide to manage your low back pain with physical activity and rehab and things like that, not only do you get the same level, statistically, the same level of pain management, but you also get all of the health benefits with increasing physical activity. I mean, it's a no-brainer, and you can still do the other stuff. So you can still get adjusted. You can still do all the other things. But if you're going to a provider that doesn't put physical activity, as a main component of your care, I think they're missing the boat. You know what I mean? It's not great. And I'm not talking about the chiropractor leaves the room or the doctor leaves the room and then some assistant or a nurse comes in and then does some 90-second script on physical activity. I don't think that's good enough. We should provide management for addressing physical activity or exercise. So that apply manual therapy only as an adjunct to other evidence-based treatments. Boom, mic drop. Unless specifically indicated, examples, red flags, offer evidence-informed non-surgical care prior to surgery. That probably doesn't apply to most of my profession unless we're working in a hospital, or if we're within the guidelines and we're actually communicating with other healthcare providers like physicians, which happens. It does. We need to facilitate communication, facilitate continuation or resumption of work. That's another big one. The recommendation just to rest. Yeah, rest for a day or two. You know what I mean? Like, you got to take the edge off a little bit maybe, but you got to get people moving again. So in summary, if you've got chronic low back pain or acute low back pain, you're struggling with low back pain, you don't have low back pain, you're afraid of it, you have concerns, or you just foresee it as something that's going to happen in your future, based on what the American Chiropractic Association recommends, right? And what all these other references are recommending, you need to find someone. It would benefit you to find someone who takes a focused history of your chief complaint, but then also does a very detailed health history of everything else. This provider should think about your mental health. Doesn't have to treat it, but we got to consider stress, the roles of stress, anxiety, and depression. They should think about nutrition. It's foundational. They should think about sleep and mood disorders and things like that. These are all things that could influence it. They should really consider if you have other healthcare problems, maybe you're not, and how those are being handled. Or if you have questions about other healthcare issues that you are afraid to talk about, we really want to get to the bottom of that. We should use a differential diagnosis process and actually we look at red flags and we try and do all these things to rule out all the scary stuff. We should do a thorough physical exam. Thorough is relative depending on what's going on. And that should not necessarily include x-rays or other imaging unless there's a reason. So if you're Again, if you're going to someone who just x-rays everyone, it's not within any guidelines that are any current guidelines. It's not appropriate. We'll say that. This healthcare provider should do their best to explain things to you, not just about the procedures, but about what's going on, diagnosis if you want to know, or at least what they've ruled out, the diagnoses, the scary stuff that they've ruled out. They should talk to you about prognosis, so how good can you get and how long will it take. They should talk to you about many different treatment options within their office, but also if you seek care somewhere else. Passive therapy should not be the primary focus. So lying still or sitting still, those types of therapies, those are adjunct therapies that can be added on. You could do them, but your activity should be centered around movement and physical activity and getting you back. And I mean, it could be centered around nutrition. Like, it just depends on what's going on, but it should be geared towards self-efficacy to help you self-manage and to not need the healthcare provider in the long term. And there should be some type of shared decision-making, which requires informed consent, which requires an explanation and a dialogue and questions asked and that back and forth. And it requires you to have a healthcare provider who resists the urge to act like they've seen it all before. Because we have seen low back pain, I don't even know how many times. And it's always described the same way, for the most part, but the management can be so vastly different. So as I said, I am going to list all three of these references in the description of this podcast. I will write a summary, and it'll be a blog post. And again, it may already be up depending on when you're listening to this. So if you're listening to this now and you check my website, buildbeyondhealth.com, go to the blog. If you don't see a blog, it's coming within the next week or two, depending on when you listen to this. I hope this was helpful. This is geared towards helping people who need help. This information should not be used, I would say, to make healthcare decisions specifically. I don't want you to go out and just change your whole healthcare plan based on what I said today. This is meant to give you some resources. If nothing else, if you're unhappy or frustrated, to go to your healthcare provider, if you can, if they're that kind of person who's open, and ask informed questions. And, like I said, don't make any rash decisions or big changes in your healthcare based on this podcast. This is just for your information. So I hope it helps. If you have questions, reach out to me. My contact info should be in the description, and you can find me on the internet. All right. Thanks for listening.